been a long way. A wait of nearly 50 years since the first time our MTP Act was implemented in 1971. And now 50 years later, we are really fortunate to have the amended Act, an act which has actually brought the dignity and the rights of the woman and the fetus into focus. For this webinar today, I warmly extend my heartfelt welcome to Dr. Sharda Jain and Dr. Ashok Khurana, the two stalwarts, the two visionaries who have actually conceptualized this webinar today. I warmly welcome my chairpersons, Dr. Achal Batra, Dr. Deepika Dekar, whose insights are really going to benefit each one of us. And I extend a really warm welcome to my esteemed faculty, who in the position of authority are going to carry out all the deliberations in this uncharted and a very sensitive area. And lastly, to all my colleagues and delegates who have logged in at this time to really make this particular session so interactive and informative. Thank you, everyone. And I now hand over to our Master of Ceremony, our Program Coordinator, Dr. Meenakshi Sharma, to take us through this webinar.
Thank you, ma'am. Is my screen visible?
Yes.
Okay. Good evening, everyone. In the DGF East and Society of Fetal Medicine webinar today evening, and we will be discussing MTP Act 2021 and management of late second and third trimester anomalies today. And we have with us addressing the August gathering, none other than Dr. Sharda Jain, ma'am, who is Director of Life Care Center and IVF. And she has been a faculty for 2 decades in PGI Chandigarh and Lady Hardinge Medical College. Ma'am is a teacher of teachers, and she's a founder and Secretary General of Delhi Gynecologist Forum. Ma'am is a member and expert OBGYN in Ethical Committee of MCI 2018-20, and again in the Medical Council from 21 to 23. Ma'am has been decorated by Lifetime Achievement Award and Living Legend Award by many professional bodies. Ma'am has a passion of teaching for safety of doctors, creating medical legal awareness. Ma'am has been instrumental in educating all the gynae people in the forum for medical legal activities and to enable them to have the latest medical legal updates so that we can all practice safely. So we hear from none other than Dr. Sharda Jain, ma'am, addressing the August gathering. Over to you, ma'am.
Thank you, Dr. Meenakshi. And at the outset, congratulations to all the gynecologists listening us for the new MTP Act, and which rightly said by Dr. Jyoti Bhaskar that it has taken 50 years, but we are all glad that there are gems hidden in this new MTP Act, and we must make the best of it. Why the gynecologists were needing all the changes? We all know that we all felt that all malformations cannot be picked up by the Anomaly scan, which we were doing in less than 20 years, this thing, but we certainly know Dr. Khurana is going to highlight more that only 70 to 80% malformations we can pick up with certainty, and the rest we could not. People like us who used to get it done routinely at scan at 28, 30 weeks, we picked up a few, and some were picked up pretty late in pregnancy. So as far as this MTP Act which has come, it has raised 2 issues which always bother me. And one issue which cheers me up, and I'm not going to deal, I think all of you know what cheers us up. There are a few malformations which are not picked up by the gynecologists in spite of the Anomaly scan and repeated level 1 scans. And these are the ones which bring litigations. And our the data from our country is available, that in somewhere where you find the faculty which comes to interrogate things, finds it like me, I save them, but there are people who get, lot of penalty for missing up these malformations. And I think, many people are listening and they are looking forward by my message and to Dr. Khurana. And I feel Dr. Khurana can be Masiha for all of you who are involved in litigations and sankat mein ubharne ke liye yahi kaam karenge. Because we find in Europe and in England, there are 11 malformations which are listed where doctors can miss. Anencephaly can be missed in 2%. Heart diseases can be missed in 50%. Kidney diseases can be missed in 70%. Now, in those cases, once this document is available and the litigations come against them, we place the document and they're all saved. We do not have that kind of a document as far as our country is concerned. So whenever the judges make judgment, they are looking for Indian documents first, which we do not have. And they don't bother to see ki England mein kya ho raha hai, unless, there's a big law which is followed everywhere. So at least my sincere request to Dr. Khurana, again, I'm making this request to him with folded hands that, he should gear up in 2022, that he should come out as a karta dharta of the, Society of Fetal Medicine in India, that he comes out with a list that these are the malformations which can be missed. And I think, this is my humble request to him, that he will definitely do this particular job in a time-bound manner in 2022. And I think this is my sincere request. And secondly, which I feel, the panelists will do a great job today, that after 24 weeks, what has to be done? And not only when we talk about what has to be done, the legal part of it, we should be within the frame of this new MTP Act, we should be acting. And secondly, the people who are sitting in the remotest area, say Uttaranchal or my state, UP, they should also have the technique, which is 100% will help them in terminating those pregnancy if I decide to terminate at 20 weeks or 26 weeks. So I think, when the panelists are taking those questions, my request is they should not concentrate about the tertiary care hospitals in Delhi. They should consider the remotest person who is sitting there when they are making suggestions, because many people are watching this particular thing. With this particular remark, I think, I'm happy to be a part of this. And I think my colleague, Dr. Achla Batra, is going to speak to you as an AOGT chief, what concerns her. Dr. Achla Batra.
Good evening, madam, and good evening, everyone. You have put it very correctly that we need to know what is to be done for those anomalies which cannot be picked up, and what is to be done if we pick up an anomaly and after 24 weeks the baby is going to be, with cardiac activity. What should be done? So we are also very concerned about these. We had put these questions up to ministry also, and they said they did not have an answer as yet, but they said they are coming up with guidelines. So once the guideline comes, only then we will be able to say that if these things are not included, which we are concerned about, that how the pregnancy is going to be terminated, like in remotest area. And very rightly put by you, what anomalies should not be the part of legal action. These things then we can take up. But I have today personally talked to Dr. Sumita. She was busy, but she said she will try to join us by 9:30, and we can ask her what is the state of affairs now. And definitely Ministry and Dr. Sumita is very responsive, and whatever suggestions we give from AOGD and from DGFS, they would definitely take it up. So let us first know what they have in pipeline, because still we are not very clear what anomalies they are going to list in the list of anomalies. So till that list comes, we cannot say anything. But then after that, definitely, and I think your suggestion to Dr. Khurana should take it as a tall order, that he has to by 2022 find out a list of the anomalies which can be missed, so that even Indian doctors can be saved. And I think today's discussion is going to be very, very fruitful. But only thing, my contention is that if we are doing a panel discussion on what can be done, maybe our ideas are okay, but we have to know what the government has to say, because whatever our ideas are, we can come to a consensus, and maybe after that we can talk to them. Till then, whatever we talk about will be just what we think, and it cannot be used. So that is what I think, So we'll have to still have a little more wait for things to be very, very clear.
Hello? Hello, can you hear me?
Hello. Yes, ma'am.
Yeah.
Yeah.
Yeah. So as a chairperson, I think this is a very important topic that we have to discuss because it is a very practical. It's from the practical point of view that it's important for us. There are not, besides the malformations which we miss, there are a lot of malformations which we can actually detect later on in pregnancy. I still remember that at AIMS, I had actually to tell some patients who wanted a termination of pregnancy late that they could go to UK and get the pregnancy terminated. So it's at one time people used to go abroad to get a bypass surgery. So I think that situation is now with us, that we should be able to do a termination of pregnancy beyond 20 weeks till 24 weeks. The practical problem that is faced is that a lot of women still come in the second trimester for screening or for biochemical screening or for even ultrasound. Malformations are detected late. You may be advising them in an IPT. They might be needing an amniocentesis. And by the time you get the reports, it's definitely beyond 22 weeks. So what do you do then? You have in your hand a baby which is not going to be in good condition, and then you cannot even terminate the pregnancy. So I think this CME on late second trimester, especially be up to 24 weeks, and also what legal actions we can take for pregnancies diagnosed with fetal malformations after 24 weeks. I think it's very relevant, and I think this topic is going to be extremely important for us today. Thank you very much.
Thank you, ma'am. Thank you for the inputs. We move on with the first academic session of the day. We have a talk on the topic late second and third trimester anomalies, a relook in the context of the recent MTP Act 2021. We have a speaker, Dr. Ashok Khurana, and the chairpersons for the session are Dr. Ashla Batra and Dr. Deepika Deka, ma'am. I will just briefly introduce Professor Ashla Batra, ma'am, is currently President AOGD. She is from Safdarjung Hospital, and she is President in Archie Delhi Chapter 2018 and 20, and Chairperson Urogynecology Committee AOGD and Rural Health Committee AOGD, and Honorary Secretary AOGD 2015 and 16. Ma'am is the next editor of AOGD, ex-editor of NARCHI, and coordinator of Foxy Critical Care Conference and Yuva Foxy North Zone in 2018. Ma'am is a dedicated PG and UG teacher for more than 35 years and conducted research projects for LSTM, ICMR, and Indo-US projects. And ma'am has authored various books in Obs and Gynae and several original research papers.
Thank you, Meenakshi. I think
yes, ma'am.
that's very kind. That's very kind of you.
Welcome, ma'am, in the webinar. And the next chairperson we have our Dr. Professor Deepika Deka, ma'am. Ma'am is the senior consultant currently in fetal medicine and genetics in Cloud9 Hospital, Gurgaon. Ma'am has been president of Delhi Gynae Forum, Dwarka. And ma'am has been former professor and unit head of Obs Gynae and chief maternal fetal medicine at All Indian Institute of Medical Sciences. And she was vice chancellor in SS University of Health Sciences in Government of Assam. And ma'am has been director of AIMS Kalyani, Kolkata, West Bengal. Ma'am has been past president of Society of Fetal Medicine and past chairman of Genetics and Fetal Medicine Committee in Foxy, and past chairman ISOPAP, North Zone. And ma'am has various.
I think we can, Dr. Meenakshi, we can proceed.
Yes, ma'am. So I request Professor Ashla, ma'am, to please introduce our esteemed speaker, Professor Ashok Khurana.
Thank you, Meenakshi. Thank you for those kind words. And it's my pleasure and honor to invite my friend, Professor Ashok Khurana, whom all the gynecologists, not only in Delhi, but all over India, know him for his expertise in, especially with the fetal medicine. And he is a chairman and consultant in reproductive ultrasound of his own lab. And he is a professor, School of Health Sciences, and he's past president of the Society of Fetal Medicine, former International Society of Ultrasound in Obs and Gynae Ambassador in India, editor-in-chief of Journal of Fetal Medicine. And we all know his expertise in fetal medicine. And whenever we are in doubt, there's always, okay, let's get it done from Dr. Khurana, and he'll tell us exactly how it is. And he's doing such great work, and he's looked upon by everybody in the field of gynecology and in ultrasound And I'm sure his inputs on the second and the third trimester anomalies is going to be of immense help to everyone. So over to you, Dr. Khurana.
Thank you. Thank you very much. And thank you, Dr. Ashla, for those very kind words. And my thanks to Dr. Deepika Decker for that introduction, and also to Dr. Sharda Jain for her guidance. Since we met a few days ago and discussed the same subject, you'll be pleased to know that we've set up a Society of Fetal Medicine committee, which is going to give out a position statement. So once we have a national academic society giving out a position statement, then it truly becomes just like an RCOG or an ACOG guideline, and that is more than sufficient. We're not going to keep it extensive. We're going to keep it a single page statement, which will be something easy for the legal profession to understand, and especially for the non-legal members of the consumer forum. And we have set ourselves a deadline, and we will have this list ready by the 20th of January, 2022, not even till the end of the year. So, and we've already started our homework on it. And so that's going to
Special thanks, sir. Special thanks.
My pleasure indeed. And I'm so glad you gave us this input. We put it into immediate effect, so that the sooner the better. And the question of taking it to the government, well, just like we took the MTP Act to the government, we realized that we had to push it ourselves. So 10 years ago, we were number 600 as far as the bill was concerned in terms of being in Parliament. And Dr. Nozir Shariar at that time was the Secretary General of FOXI at that time, and also part of the, he was chief actually of the FOXI MTP committee. And he first pushed these modifications, and I was working with him at that time to push these. And then after that, Dr. Pai and Dr. Jaideep Malhotra took over and gave it the final push at the ministry level. And we realized that our biggest problems were with the NGOs, who refused to understand what we were doing. But thank God, we were able to convince Dr. Shumita Ghosh to be with us on our side, and she understood the problem very well. And we finally had this new act, which Dr. Harshvardhan put forth himself through the Rajya Sabha, when we thought we may get stuck up at the last moment. So we now have a beautiful act that is already in use. We already had guidelines before this, but the act makes it much simpler. And I will highlight what we have achieved, because every day really in and out, we see things like a microcephaly, which we don't pick up at the time of the anomaly scan. We see chondroplasia, which cannot be picked up before 26 weeks. And we pick up duodenal atresia, like you see over here, which truly we pick up only when the fetus swallows enough. And the fetus swallows enough only after 22 weeks. So we no longer are stuck with that. And so we finally have the rules that have been framed. The act was actually passed in February, after which the committee sat down and made the rules. And the rules really make it very clear on how we are supposed to approach the whole problem. And we know that, yes, this is important, because we've been looking at this sort of a problem for a long time. We do know that there are late second and third trimester anomalies, and this list is from Dario Palladini's textbook, which clearly says there are so many that would be spotted, in fact, after birth, never mind the ones that you would spot much later in pregnancy. And these include some pretty common things: achondroplasia, like I said already, a vein of Galen aneurysm, fetal tumors, renal cystic disease, some diaphragmatic hernias, bowel atresias, and a large bunch of cardiac anomalies, including the agenesis of the corpus callosum, which sometimes you may not pick up until 22 weeks of pregnancy. And we've had information on this through lots of papers in the literature over the last few years. And we realized that we really had to move in a direction where the wisdom of these papers had to be put forth. And the final push came from this paper, which was from Kypros Nikolaidis' group, where we had the suggestion that, look, in assessments that we do at 35 to 37 weeks of pregnancy, we do realize that the incidence of fetal abnormality was as high as about 2%. And although there was a bunch of these which had been diagnosed early and the patient had decided to continue, there were 7.4% of that 2% that were detected for the first time postnatally, and almost 1/4 of that 2%, that means 0.5% of those were detected for the first time at 36 weeks. So obviously there we had to give our patients some choices. In Germany, patients have a choice. In the UK, patients have a choice. In several parts of the Soviet satellite states, people have a choice. And we thought that we must let our patients also have that choice. After all, they do get the sort of medical help that we are willing to give them all the time. And so the first thing that we did was that, okay, we will categorize these abnormalities that we see and then go step by step. So we do understand that there will be some patients who've been well investigated, and even though we spot an omphallocele in the first trimester, they've continued because the genetic evaluation was normal. There were good prognosis features in this. It had only the liver, it didn't have too much of bowel, and it was a small omphallocele. And sure enough, after birth, this fetus was operated. The child is doing extremely well. Then there are, of course, that group which are the truly missed abnormalities, where either as a matter of chance or fetal position or not following a protocol, we are not able to pick up things like neural tube defects. And that, unfortunately, is a failure of the profession. But we know that nobody is 100% accurate, and we have enough papers to highlight that as well. And then there is this group, like cystic kidney disease, enlarged echogenic kidneys, which will never be picked up except in the late second trimester or in the third trimester. And then a very important group where the anomalies evolve during pregnancy. And therefore, what we truly see in this situation is the fact that, okay, we have one chamber of the heart, the left ventricle, which is echogenic, which is small, non-contractile, adynamic, and this is critical aortic stenosis. It would be somewhat manifest if you happen to do a Doppler evaluation of the aortic valve at 26 weeks, but there is no protocol in which we do that, and therefore this is something that will show up only later. So that group is the one that we have to particularly look out for and say, yes, this is what we will spot when we do our routine growth scans. And then, of course, some where the insult is late, that either an infection has taken place or a vascular incident has taken place where there's been an infarction. And therefore, then you realize that you will have findings that will show up only in a third trimester scan or in a growth scan done after, say, 30 weeks or so. So having realized that, we realize that there is this huge number of abnormalities that will not be picked up, and therefore we needed to do something about them, and the MTP Act really took this into consideration. And it's not that this was happening only in India. Even in the great registry in Europe, which we call the EuroCat registry, we realize that there are some excellent centers, including those in Paris, where a large number of abnormalities would be picked up either not at all in pregnancy or would be picked up very late in pregnancy. And the one thing that we've become aware of is what we call the physiological, the embryological timetable, where you have certain structures that appear much later than this particular time. And what are these? The cerebellar vermis and the cisterna magna might not be picked up adequately at that time. The corpus callosum appears later. Microcephaly cannot be picked up before about 24 to 26 weeks. Skeletal dysplasias, usually the non-lethal ones, will be picked up only after 26 weeks. Bowel atresia would depend on when the fetus starts swallowing, which again would be about 24 weeks onwards. Obstructive urological disease might not manifest itself until as late as 32 or 34 weeks. Restrictive cardiac lesions will always be a third trimester diagnosis. And then, of course, the tumors, vascular and inflammatory changes that I mentioned. And therefore, we realize that beyond just simple embryology and realizing what that the 20-week scan would be the end of everything, we would be able to see structures only A, when they are formed, B, when there's appropriate fetal physiology, that things do evolve, and if the underlying etiology is something that manifests late, yes, as I repeat again, this will be picked up late. So where do we stand now? The good news is that the legal termination is now possible up to any time in pregnancy when we are looking at anomalies. In the 1971 Act, we had it only up to 20 weeks. And in the modifications in 2021, we can now terminate this at any time. But I will show you what are the rules and how it works out well and how best we are supposed to be handling this. And then, of course, the panel will take this threadbare and we will have answers. Importantly, we kept in the background the fact that this was fitting in with the United Nations Sustainable Development Goals on ensuring healthy lives, and specifically goals 3, 3.1, 3.7, and 5.6. So within that, then these sections were added to section 2, 3, 6, and a new section 5A to the original Act of 1971. So there's a lot that was left over from the original Act, and these 4 sections have been added, and this is what I will specifically discuss because this is relevant for us today. So we have amendment of section 2 of the Principal Act, which said that there will be the word insertion of medical board and termination of pregnancy as clauses A and E respectively in section 2. And this means that the states will actually constitute medical boards because, you know, health is a state subject, not a central subject. And all the union territories will also do the same thing, that we realize that if you diagnose substantial fetal irregularities, then the medical board will examine these and give instructions. Then there is amendment of section 3 of the Principal Act, which sets out to increase the gestation time limit and allows termination possible by a registered medical practitioner beyond 20 weeks, but not exceeding 24 weeks. And it permits abortions on several grounds, which we will discuss. And then, of course, the amendments in section 6, which says that which is the category of women who can actually take benefit. And truly speaking, the important thing was that originally in the Act, only a married woman could seek termination. And that was really something that was more, I think, something missed out when the Act was being put together. And thank God that has been corrected, because every woman should have the right to decide what her body is going to be subjected to. And this was becoming very important, because we do realize that when I look at the amount of abnormalities that we in general, and this is world data, pick up when we were stuck with an early scan in pregnancy. That means when I had a 20-week limit, I wanted to do my scans at 18 weeks, I was going to be picking up only between 50 and 60% of abnormalities. Compare that with what I can do now at about 20 weeks, where I pick up 70 to 80% of abnormalities. So the first implication of this Act is that the routine mid-trimester anomaly scan, old-fashionedly called the level 2 scan in most parts of our country, can now be shifted to a 20 or 22 weeks window, which has a higher detection rate. This will still leave us the old window we had of about 2 weeks, and now even more, because we can go all the way till 24 and even beyond 24 in particular situations, for second opinions, for counseling, for multi-specialty consultations, and further evaluation with genetics where required, with an MRI where required, and other lab tests as necessary. And so even if genetic evaluation takes us a while, and you move on to not just the first year genetic testing, you move on to a second or a third year testing, and the result goes beyond 24 weeks, the medical board will still give permission to say that, yes, this is an abnormality where the quality of life of the fetus is going to be in danger, and decide that, yes, this patient will be given permission to terminate that pregnancy. So that no longer hangs around as a sword on our necks. Then we have implication 2, which is about the level of termination. I mean, at what stage of pregnancy can we do it? So the new week limit is 24 weeks. And this clearly says that fetal malformation that has a substantial risk of being incompatible with life, or if the child born may suffer from such physical or mental abnormalities to be seriously handicapped, then all you need is 2 medical practitioners to allow this, and you can terminate up to 24 weeks, and you don't require court permission, and you don't require board permission. So we know that in the old Act, we required 1 practitioner up to 12 and 2 practitioners between 12 and 20. Now we have 1 practitioner up to 20 and 2 practitioners for between 20 and 24. Very straightforward, very easy to understand, and certainly no argument that this can be seen in any gray zone. Then we have the other portion, and that is that for when we go beyond 20 weeks, and when we go even beyond 24 weeks, then we stop having the permission of just within the profession being able to take a decision. And then we realize that that goes on to the board. But between 20 and 24 weeks, there is just a Form E to be filled up. And that Form E is something that is a very simple form. It's a one-page form, easy to fill up by you and me. And it's all that is required for terminating that pregnancy. So you and your colleague and a Form E is all that is required, provided you have the skills and the situation. The immediate question that arises, where do I get a copy of Form E? And the second one is, where do I get a list of the permitted fetal malformations? Both of these are very clear, and you could either get them on Google, or you could get them on the Ministry of Health and Family Welfare website, or the Government of India website. And of course, you will also find them on the Society of Fetal Medicine website, which, as you see here, is www.societyoffetalmedicine.com. So when you are stuck with this situation, this is nothing that we have to wait now in the future. This is already here. So tomorrow, if you have a lethal abnormality and you are sitting at 23 weeks, you can decide on your own with a colleague to sign that Form E, and you are absolutely straightforward allowed to do that termination of pregnancy, provided you can give requisite care. Now, the next thing is that in the third implication comes from Section 3, which says that beyond 24 weeks of gestation, the whole matter moves to what is called a medical board. The medical board is something that is constituted by the government and should consist of its the people in the board is a gynecology department, radiology department, pediatrics, and any other specialist in that department, and you could include counselors there as well. And then they will come to a conclusion. If necessary, they might ask for additional investigations. And importantly, the medical board will fill out something called a Form D, and this has to be done within 3 days of receiving the patient's request. So the patient or her representative can petition the medical board, and they have to give that permission within 3 days, and they have to ensure and give directions that the termination of pregnancy will happen within 5 days of the receipt of that request from that particular patient or her representative. So the law no longer remains ambiguous. There is a time slot there, and we don't have to wait for weeks and weeks for the legal process to happen. What they refer when they talk about 3 days and 5 days is that this should be working days, and all working days are all days of the week except a second Saturday and Sundays, of course. So there is no question of getting worried about that. Now, the other thing that we have to understand is that there's one clarity that we are still seeking from the ministry, and that is that, yes, we have to get permission from the state medical board, but what is the address of the current state medical board? And we know that some of the states have not appointed this board as yet. While we are waiting for that, for the state medical board, I have received a notification from the, well, not a notification, but a communication from the ministry to say that in the meanwhile, we can put a writ petition in the district court or a writ petition in the high court. Technically, a writ petition can only go to the high court, and a petition can go to the district court, and they can ask their local civil or district hospital to put together a board. So the medical superintendent of the district or civil hospital puts together the medical board consisting of the gynecologist, radiologist, pediatrician if necessary, and they will then decide that yes, permission can be given. So while the state medical boards are being constituted, you can get permission through a writ petition in the High Court or an appeal to the district court. The rules of 3-day and 5-day will still apply to this whole situation. So that then brings us to our daily practice. What do we do? Late anomalies. How can we prevent a detection of late anomalies? Well, the most important thing is that you stop doing ultrasound scans, which doesn't make sense. why should a radiologist or a practitioner of fetal medicine or a practicing obstetrician stop doing it? What we have to do is go through these, which I will take you through briefly, and they will be also discussed in a lot of detail in the panel discussion that follows. So we'll go through aspects of what we refer to as damage control, which means we prevent further wrong experiences for the patient to go through, for any tragedy to the patient to go through, etc. We will talk about the spectrum of these anomalies, the legal considerations with the patient options in particular situations, also how to assess prognostic factors in this group of late onset anomalies, prognosticating future pregnancies, which is very important. And in that particular pregnancy, we will discuss to what extent we will help in improving the outcomes. So that is what we will discuss for the rest of the evening. For primary prevention, of course, there is this tragedy of saying, look, stop obstetric and ultrasound practice, which makes no sense. The important thing is if we follow the protocol of an 11 to 14 week scan, which is not only an NT scan for aneuploidies, but also for structure of the fetus, we will get good answers. We ensure that every patient is offered a good anomaly scan between 18 and 22 weeks, preferably at 20 weeks, so that we can pick up more. And they should be done by people who have appropriate equipment and appropriate expertise. We must follow an appropriate protocol, and we know we have ISWA protocols, SFM protocols. We also have the option in all these protocols of what we call an institutional protocol, which means that an institution recognizes the fact that they have either lack of number of experts, lack of equipment, or an overwhelming number of people wanting that facility. And then they just put in the institution protocol, and this ABCD is what we will see. If you want more, please go elsewhere. Then, of course, we must clearly mention what are the limitations of such a scan and patient-specific limitations such as oligoamnios, or such as patient habitus, or as fetal position, advanced gestational age, must be documented in the report so that at one glance, we come to know that, yes, this is something that we will go through. It also gives me great pleasure to welcome Dr. Sumita Ghosh, who has now joined us. And I'm so glad because she was really the prime mover in putting together the guidelines that we used to use until the Act came through. And then, of course, with her support, we've been able to now sustain the concept of the medical board. And I will be eternally grateful to her on behalf of all the women of this country for giving them this right to their own bodies. Now, the other thing that we must realize is that if you're not happy with the scan, we must ask for a second opinion. And then we openly discuss with the patient. From your point of view, it's important as a clinician to keep your indemnity insurances high and up to date. But most importantly, counsel before a scan, counsel during a scan, and counsel after an ultrasound scan, and preferably with the whole family concerned, because that is the unit in our country is not a patient. The unit in our country is not the couple. The unit is really family. So in case there are things to be discussed or something in the family history that needs to be discussed, then that should be with a much larger group, and it should be part of our protocol. The protocols are available, as I said, free on the internet from various situations. And let me go on to a few examples before I close this discussion. The first bit is that look at this mass, which was really very tiny. And if I wasn't on a high-end machine, I might have missed it. And if I did, then what do I do? Well, when this patient does come to me later, I assess the level of the lesion, where I count back and say, okay, this lesion is located at about the lower sacral level. I can see a termination of the cord, which seems to have come down all the way, as you see the top left image. And I seem to think that the cord is ending somewhere at the lower lumbar level, whereas it should end at the L3 level. I notice that the cord has tethering bands into the meningocele, and therefore this then becomes a cause for grave concern because the prognosis is poor. The chances of hydrocephalus are 100%. Weakness of both lower limbs as the child grows is 100%, and failure of the entire urinary system in terms of neurogenic bladder and chronic renal failure would therefore be starting to happen by the age of the third or the fourth decade. So that's a poor prognosis pregnancy. And although we have this background of going into the genetics of it and seeing what it happened, well, that is something we must do. Genetic consultation, go into the history of teratogens such as the anti-epileptics or the antidepressants, the anti-acne medication and so on, and then realize that also there are non-genetic causes for this kind of a thing, and we must also include the background of diabetes. Having gone through all of that and looking for associated abnormalities, one would review the family history and teratogen intake, do a genetic consultation, discuss quality of life issues, work out whether an MRI might give further information, arrange a pediatric or neurosurgery consultation, a rehab consultation, or even if you can get on-site all these specialists on board, that would be nice, or we could do it virtually as we've done in the COVID era. Then a medical legal consultation. And this is where the protocol changes, that the patient now has, after all of this and understanding the problem, the option of a late termination. Previously, there was no question of a late termination. We had to accept the destiny of the family and the destiny of that individual, and delivery would take place at a tertiary center. And then we would consider folic acid in future pregnancies, and that would be the way. But now we have the option of late termination, and that is something that we can do. Another common example, agenesis of the corpus callosum. We know that this is completed only by 20 or 22 weeks, and therefore we might not pick it up. And we go through the same thing, associated abnormalities, family history, and MRI when we diagnose it, a genetic consultation and invasive testing. And then, of course, we realize that this has a variable prognosis. Yes, we can suspect this problem even in the first trimester, but a complete diagnosis comes only after all of this. And again, after a multi-specialty consultation, we realize we have that option of late termination to be offered to the patient. Of course, we realize that yes, in an isolated agenesis of the corpus callosum, we must tell them the truth. And that is that, look, if it's isolated, 90% chance of poor prognosis and 10% chance of 90% chance of good prognosis, 10 of poor. But we may not pick up all the associated abnormalities. And therefore, I cannot give you in black and white what the statistics are going to be. And therefore, then she has to decide accordingly. So that option of late termination then comes here, because the patient might opt to say that, no, I don't think I want to continue with this. And a mother now has a right to do so. She herself on her own can say, look, I don't want this pregnancy, and it can be at any stage of pregnancy. The same thing is with the late onset pregnancies of the bowel atresias, the duodenal atresia, which we often pick up only at 26 weeks or even 28 when we pick up polyamnios. Again, we look for associated abnormalities, cardiac abnormalities, evaluate for trisomy 21, and then offer a late termination. Apart from late termination, as we will discuss in the panel, there are some other options, but the late termination has to be offered at this stage so that she can make a choice. Now, what are the other situations where we have to be a little more sensitive to what is going on? One is this, that when we talk about achondroplasias, these are people who are intellectually completely normal. They have a physical abnormality, and they have the tendency towards lumbar canal stenosis as they grow older, which is pain and increasing disabilities. But the true physical disability is not so much as a psychological disability of being a short-statured individual. Now here, yes, our diagnoses are made late, almost always after 26 weeks. And yes, in certain pregnancies, we can offer in the next pregnancy, for instance, NIPT for the FGFR3 analysis. But what do we do in this particular pregnancy? Are we supposed to accept termination of a pregnancy only on the basis of the fact that this will be a physical disability without an intellectual disability, and that the patient can actually grow up and have a job, go to college, etc., etc.? Well, this is where we have to draw a balance between patient choice, the fetus's right to life, and the mother's right to acknowledge or not to acknowledge the tragedy that is the Indian community, where for us a physical disability is something that we will say, okay, I will not get my child married into that family, or I will look down upon somebody with a physical disability as someone who cannot be accepted. Now, that is something that is completely tragic. And therefore, this business of quality of life issues, maternal rights versus fetal rights, is something that will have to be always considered along with all the cultural considerations. So this does become a gray zone, but again, it's a question of counselors to sit together, of doctors to sit together with the patient, specialists to sit together, the medical legal aspects, and then make sure on who gets the right. Does the fetus get the right? Does the mother get the right? And what are the true quality of life issues? The same thing happens in urinary dilatation. We are able to give you a lot of information. Where is the obstruction? We then put into effect a risk stratification based on protocols that are available. We go on to say that, yes, indeed, we can look back at the first scan and say what the prognosis is going to be. But when it comes to doing interventions, we actually realize that just putting in the psychoamniotic shunt doesn't seem to work, but the answer seems to lie in utero endoscopic valve ablation, for which the window is very early. That window is between 18 and 22 weeks. So what if we miss that window? The outcome is poor. And therefore we realize that, yes, this is where you give the option of late termination. Yes, but some of them will manage on their own. The ones that manage will manage on their own, not because of us in fetal medicine intervening. So here again is a situation where we have to realize that the quality of life issue needs to be considered. Then there is cardiac anomalies. Yes, we spot an anomaly, patient decides to carry on, no problem with the genetics. And then we make sure that the child gets born, where we keep the ductus arteriosus open with the help of prostaglandins, and that seems to work. But we must realize that the quality of life issues come into the circulation right away. And that is that, yes, although we can give hope to patients with aortic stenosis and an evolving hypoplastic left heart, or we have a pulmonary atresia with an intact ventricular septum, what do we do? Well, the question is, they may not have a good quality of life, and what would the parent want? Yes, in some patients, we've done some salvages with mitral valve dysplasias. We use sirolimus for rhabdomyomas and so on. But the large number of situations which we don't seem to understand is that inherently neurological developmental abnormalities can be present in cardiac abnormalities. And this is something that the patient should be aware of. Yes, we can even say things like, okay, if I have a vein of Galen aneurysm, I will embolize that. But will my fetus have an intact outcome? No. And therefore, again, the parents have to be counseled and say, look, again, quality of life issues, and what would you like to do? So the take-home message here would be that, look, our job is to ensure a complete workup of each finding, ensure that associated anomalies are excluded. We don't limit the use of technology to come to a complete diagnosis, and we can take multiple opinions, MRI and genetics. We should know the natural history and outcomes. We must have a working knowledge of surveillance and treatment options. We must facilitate specialty consultations for these patients, be aware of quality of life issues and assess the preference of the couple. And then, of course, perinatal care in these special situations. But the trick lies in counseling, and the option of late termination. And I know this will be adequately discussed in the panel discussion. And thank you so much for your attention.
Thank you so much, sir, for the exhaustive talk, and it very nicely elaborated various situations which will come in, which needs proper counseling and multidisciplinary management. And I request our chairperson, Dr. Deepika Dika, ma'am, to please make a comment.
Yeah, yes, yeah, right. So I think we have laid the base for which we can now have the discussions. I think it's pretty late now, and we could even just, I can see there are a lot of questions in the chat box, and then the panel discussion is coming up. Certainly, Dr. Khurana, as usual, this has been a very, very elaborate and a very clear description of what is going to come and how we could all be prepared for the changes after the act is in place. So I think we could now go in for the chat box, or we can go directly to the panel, and Dr. Atula might have something to say.
Yeah, I think a wonderful talk by Dr. Khurana, and I think the list of anomalies, if like he had said, if they're there, then it is very good. And we also have with us, Dr. Sumita has joined. So I would want if she wants to give any comment on what Dr. Khurana has talked about or anything else she wants to say. Dr. Sumita?
We are all eagerly looking forward for her statements.
Thank you. Thank you. I am rather glad that I can listen to your, such, erudition and discussions. Dr. Khurana's presentation, I could catch only the last few slides. That a new act has come and the rules have come. We are doing our best to, give clarity to each and every issue. But the limitations are there, that not much experience is available, not much expertise is available. So we'll be learning on the way. So don't expect that everything will be very, very clear now. So that is my point, that we are also learning, because this has never happened. The beyond 20 weeks, the expertise is really, really limited in our country. Even head of the departments of medical colleges, when the courts used to tell that this has to be, opined upon and the actions have to be taken for late terminations. Even head of the departments of some medical colleges will also call up that we have never done it, what to do, how to do it. So challenges are there, but the intentions are very clear in the act, that if in case the fetal anomalies are incompatible with life, or there is very, very serious probability that the child, if born, will be very much physically, mentally, or otherwise. The words are, that substantial. So a lot of responsibilities have been put on us, and we must have, and already because of the court cases, we have a list. Dr. Deka is here, so she knows, and Dr. Khurana also was part of it. We have the list, but again, we have to be very, very careful and cautious that the real intentions behind this liberalization of the act, actually those cases which are really have a very, very little chance to survive, or very serious chance of being handicapped. So those things are to be decided upon, and I would like to listen to the panel discussion and the issues that are coming up because of this opening up these new vistas. So what will be our challenges? So I would like to listen. Thank you very much for letting me in. Thank you.
But Dr. Ghosh, it would be very important to know, when are we going to be able to do it? When is the act going to be implemented?
It is already implemented.
No, I mean, we have to still get the orders.
No.
Rules are there. It is gazetted. So you are free, once it is in the gazette, you are free to do.
Once the gazette is out, you can start.
It is enacted started. And the rules guiding it have also been declared, defined. So it is for all. Yes, boards are there. I could see some questions. We have some 174 boards already, medical boards in the peripheral. Mostly it is only in the medical colleges in all over the states. Yes, the least of that is the states have given us. But again, each state has, sometimes they change, sometimes they, make modifications. So the list which we have, we can share, but again, it will be the duty of the, concerned practitioner to confirm with the states where the boards are. Basically, a lot of boards are there, and only I think one state is yet to come out with a defined board, but others all have. So it is there in plenty. But again, the guidance note on boards. We have already prepared, but like listening to you, so many new points, finer points come up. So it is in shape. So it will be soon be given to the states, and the boards will be gazetted.
Thank you so much, madam. And I hope you will stay with us for the panel discussion, because we have a lot of questions in them where I think to answer those questions.
Yeah, sure.
Great. If you could just stay for another half an hour to 40 minutes with us.
Thank you, Dr. Sumita, for joining, asking you so late, but you agreed. That is so nice of you. Thank you very much.
So Meenakshi will go ahead with the panel.
Yes, ma'am. Thank you, ma'am. And now I will be just introducing the panel presently. And this is the second academic session of the day, where we have a very nice panel with esteemed panelists and moderated by Dr. Jyoti Bhaskar and Dr. Krishan Gopal, who are going to enlighten us on this new act, MTP Act for Fetal Anomalies, and how to apply it in our practice. And we look forward to many questions, which we hope will be answered in this panel. I'll just briefly introduce our moderator, Dr. Jyoti Bhaskar, ma'am. She's a principal consultant of Gynae Apollo Cradle Hospital, Indrapuram, and ma'am is presently president of Delhi Gynae Forum East. And I will be just briefly introducing Dr. Krishan Gopal. Is a clinical fellowship from Singapore, General Hospital, Singapore, and is Fetal Medicine Foundation, is London certified, and is a national secretary of Society of Fetal Medicine, India. And we have a panelist, Dr. Ashok Khurana, sir, who is just already given a lecture and is introduced in the forum. We have with us Dr. Malvika, ma'am. She is a Padam Shri and a founder chairperson of Delhi State IEG and president of Delhi Gynae Forum Central. And we have Dr. Asmita Rathore, ma'am, with us. She's director, professor, and head of the Ops and Gynae department in Maulana Azad Medical College, with her area of interest being maternal fetal medicine and vaginal surgery. And we have Dr. Sangeeta Gupta, ma'am. She is an ex-HOD Ops Gynae from ESI Basadapur, and she's founder secretary of Delhi Gynae Forum. And she's a member of the Safe Motherhood Committee in Foxy. We have Dr. Aparna Sharma with us. I think she would be soon joining us. She's an additional professor in the Division of Maternal Fetal Medicine in Ops and Gynae in AIMS. Dr. Aparna is a fetal medicine specialist, expertise in fetal intervention. She is joint secretary of Society of Fetal Medicine. And we have Dr. Jyoti Agarwal, ma'am, with us. Ma'am is a senior consultant and director at Life Care Center and Life Care IVF. Ma'am is advisor of Delhi Gynae Forum East and an esteemed academician. And she's a DZF certified trainer for infertility ultrasound and corpuscopic thermal ablation. So I hand over my mic to Dr. Jyoti Bhaskar, ma'am, for conducting the panel. I'll just be stop sharing. So over to you, ma'am, for the panel.
So Dr. Gopal is going to start and take us, giving the starting touch to it. So Dr. Gopal, over to you.
Dr. Gopal, please.
Good evening. Thanks, Delhi Gynae Forum and the Society of Fetal Medicine for making a part of it. And I'm thankful to my senior, Dr. Ashok Khurana sir, and Dr. Tiran Parveen sir also, who has conducted a similar panel some times back. So it is an honor to have such an esteemed panel with me. And to go to the case straight away, the first case is a 32-year-old gravida with a low-risk combined test. First trimester anomaly scan was normal, had a 19 weeks normal mid-trimester anomaly scan, and she is now 30 weeks of gestation. So my first question is to Dr. Malvika ma'am, that when would you prefer an ultrasound after normal second anomaly scan in the private setup? Ma'am, please.
Am I audible?
Yes, ma'am.
Yes, ma'am, please.
Thank you so much. And I must congratulate Dr. Jyoti, Dr. Meenakshi, Dr. Sharda Jain, first of all, Dr. Ashok Khurana. My God, what a wonderful talk you've given. Absolutely very explicit, wonderful. So coming to my question, Dr. Gopal, you asked me that the first... Am I audible?
Dr. Sangeeta.
Yes, ma'am. Yeah.
Okay. Considering that, this is a patient in our hospital, whenever we do an anomaly scan, that is a second trimester anomaly scan, which is normally in our hospital done at 18 to 20 weeks. In fact, just after this thing was organized, I just said that we must start doing it so that the pickup becomes a little better. So far we've been doing from 18 to 20 weeks, and all of them go for a fetal echo thereafter. So after the second trimester anomaly scan, as a routine, we send our patients for fetal echo. Firstly, I mean, this is something which I really realized, that the CHD, the incidence is 1%. And also it's a very leading cause for infant mortality. It's almost like 4 to 13 per 1,000 live births. For such kind of things, if a good fetal echo is done, and of course it is operator dependent, and if it is done on time, and if the pickup is good, you can have, you can design the pregnancy being, you can deliver in such a way that these structural problems which are picked up in the fetal echo can be corrected. So we always do a fetal echo after the first anomaly, the second anomaly scan, the second trimester anomaly scan. This is something which we do as a routine. But for this particular patient, when we talk of this patient who you have just mentioned, Dr. Gopal, I would definitely ask her to go for an ultrasound and for an obstetrical Doppler now, because we don't know where the second trimester anomaly scan was done to begin with. So maybe we do not know, because I may not be knowing what the operator was like. So it is very operator dependent. Then I would definitely send her for a second for an ultrasound and also an obstetrical Doppler. Also, one more very important thing, I think it's a wonderful thing that now the late second trimester anomaly scans are being done. So there will be, the pickup rate is going to be much better. So the later, and of course, if you scan at about 22 weeks, like Dr. Ashok has already mentioned, that so many structural abnormalities will be picked up now. So we're very happy about that. And that is the way to go. And we will move ahead. I think we should be happy doing such scans now. We'll be really very happy to send them for scans at a late, that is late second trimester scan. But this particular patient, we'll send it now. Right away, we'll sensitize her, that we should send her for Doppler as well as ultrasound.
Thanks, ma'am. But basically, India is a diverse country. It has a different sets of healthcare. We have a very good hospital. We have our general OPDs also, government setups also. So we don't have always this facility of sending to the fetal echo and detailed ultrasound. So I will rather put the same question for Dr. Sangeeta Gupta, ma'am, for a government setup, where there is a resource where all the facilities are not there. Resource restriction is there.
Dr. Sangeeta, could you unmute yourself? Could you? I think there's a
Dr. Sangeeta, ma'am. Dr. Sangeeta Gupta.
I think the same question till she unmutes or manages herself. Dr. Asmita, she's also from the government, so we could just ask Dr. Asmita the same question.
Yeah, I can come in. Thank you. And at the outset, I think I must congratulate the organizers for this very relevant topic for discussion today and making me part of this. As far as public sector is concerned, I think we don't have even the logistics for offering routine scans at our institutions to all our patients. So what at this point we do is whatever we can accommodate within our list, we give them, and then we offer them that though we do not have the facility, this can be done outside and you can accept if they can. Coming to the third trimester scan, there is no protocol of routine third trimester scans in any of the public institutions. We only do indicated scans in the third trimester. So I think for this patient with a normal first and second trimester screen, we would not offer any third trimester scan unless we find something clinically suspicious.
Sorry, Dr. Jyoti, I could not answer because of some problem. Now, as Dr. Asmita rightly said, that in government setup, it is very difficult to do repeated ultrasound. So what we are getting done is a routine 11 to 14 weeks ultrasound. After that, second trimester anomaly scan. And after that, in low risk cases, we are not in routine getting any ultrasound done after the anomaly scan. But of course, if we found some suspicion or there is some high risk factor, we get an ultrasound done at 34 weeks or serially if required. So there is definitely a difference in the number of ultrasound in a government setup and in a private sector.
Ma'am, if a choice is given after this talk of sir, which week you will
Definitely from 20 to 22 weeks.
No. After 20 to 22 weeks, which scan in after 32 weeks?
In the third trimester. In the third trimester, given a choice, which gestation would you
35 weeks
choose?
to 37 weeks.
37 weeks.
Yeah.
Okay. So, sir, what are you looking for in third trimester ultrasound? To what extent we can look for the defects, anomalies in this scan, and what are the common anomalies detected in late second and third trimester? Can you please let the audience know it?
Yeah. Thanks, Krishna, for that question. Basically, when we're talking at the moment about a third trimester ultrasound scan, we're referring to the recommendation by Kypros Nicolaides of doing a scan at 36 weeks, the 35 to 37 weeks window, because it truly guides us on quite a few things, particularly reconfirming fetal position and placental position, in addition to that growth restriction. And then so that would be my two main things. My biometry and fetal growth is something I must go in for. And in addition to this, the question is, do I do a multi-vessel Doppler? Since my assessment of growth is no longer dependent only on biometry, and since a lot of my patients will not have a previous scan well documented, I must do a multi-vessel Doppler for every scan that I now do at 36 weeks in an ideal situation. Yes, all over the world, we understand that we have resource restriction, but for those patients who can afford it, they should be offered this scan. In addition to this, we say, okay, I will try and pick up as much of the anatomy as possible. We do understand that because of patient position, the fetal position, and because of the fact that the skeleton gets fairly ossified, I'm not going to be able to get such a good view. If I don't get a good view, I will mention in my report that it was evaluated, but was limited by advanced gestational age and also fetal position. Then I would go on to specifically look for those which I would only pick up at this stage because the patient has had no scan in between. So that would include things like the bowel atresias and the urinary obstructions. I would then also make sure that I would do my entire anomalies protocol at this stage. There's no doubt that in the original paper by Kypros Nicolaides, he said that they picked up fetal ovarian cysts, microcephaly, achondroplasia, dacrocystocele, and hematocolpos. But the fact is that these aren't as important as the ones that were actually missed, such as some of the cardiac defects, which were not picked up because they didn't have an interim scan. In India, because we have a huge incidence of growth restriction, where simple interventions like maternal nutrition can be improved upon tremendously, I would suggest in those patients who can afford it, they should have a 30-week scan, because that is the time that you can fine-tune the mother and ensure that she eats properly. So technically, I would like one scan at that time, but I know that there is this question of resource restriction. And so we have to then accept the fact that the country has to be bifurcated into two. Those that are the non-affording patients, and they can be offered it and they can be told that you can get this done. And out of the ones that can get it done, they should be offered it on a regular basis, one 30-week scan and one 36-week scan. And then, of course, we must even at this time counsel them that there can be some abnormalities that we don't pick up, such as isolated clefts of the heart palate, such as digital abnormalities. And of course, because we don't look at the genitalia or they're not very well seen by this stage, we'll miss out on some of those as well.
Thanks, sir. Thank you so much. So my patient went for an obstetrical ultrasound, which reveals finding of lethal skeletal dysplasia. Anxious and shocked parents came back to a doctor obstetrician. They wanted to know why this was not detected at 19 weeks anomaly scan. So, Dr. Jyoti Agrawal, ma'am, how would you counsel these parents?
It's absolutely shocking news, Dr. Gopal, not only for the patient and her family, but also for the doctor. सबसे पहले सुनते ही रिएक्शन होता है जमीन के पैरों धरती सरक गई. But yes, we need to relax. We need to counsel the patient, and counseling becomes very, very important. Make the patient relax, make the patient sit down, take the patient into confidence and spend time with her. Tell her that we don't have to discuss ever by mistake anything about the 5th month ultrasound कि वो report दिखा दो, उसमें क्या बताया था, अभी क्या. Never ever do this mistake. Just flood her mind with positive counseling in a very compassionate manner, because this is a very sensitive issue. अब तो टाइम आ रहा था काउंटडाउन शुरू होने का, और अब पता चल रहा है कि मेरे बच्चे को तो lethal skeletal dysplasia है. You just have to tell them pregnancy is a dynamic process. It is an ongoing event. Every day the fetus is growing, and this is the right time to pick up these kind of anomalies. It cannot be seen earlier, and by no means we can hasten this physiology or the embryology path. And we need to be very compassionate and sensitive while talking to them, and we need to spend time. And in case we have the facility, and if possible, we can give them some reference articles or the links so that they become very clear. And I will not do it all alone myself. I will take the team into consideration. I'll take ultrasonologist into opinion, the pediatrician, the pediatric surgeon, or the cardiologist, or whosoever is needed, so that everybody talks the same thing, and then the patient is more pacified. And not only one counseling, many a times we may need one or more than one counseling till the patient is satisfied. And the main thing is not to discuss or utter a word against the 5th month ultrasound or any of your colleagues. Dr. Gopal has very aptly put on the screen that you never look good trying to make someone else look bad. So this is how I will go about, sir.
Thanks, ma'am. So, Dr. Aparna Sharma, why are few of the anomalies detected in the late 2nd and 3rd trimester? Which classification would you like to follow for the assessment of severity of congenital anomalies detected at 35 to 37 weeks?
I think Dr. Gopal, Dr. Aparna has got stuck in a case. So
I would request Dr. Ashok Khurana sir to please take this question.
Yeah, there we are. So we try to broadly classify those as those that were not possible to see earlier and those that were seen earlier and have been followed up. Those are the two broad categories. Then the next thing would be that, yes, we just happen to spot anomalies that are of not much consequence. And that is that, yes, I do spot the odd additional digit, or I do spot an odd a difference in the scapulae, or one scapula missing, things like that, which don't really have much of a consequence. Then, of course, there are those that were looked for in the previous one, but were not picked up, and that is a fairly longish list. And then, of course, there would be those that are just evolving throughout pregnancy, like I mentioned in my original talk. And vascular insults, infections, and then, of course, a lot of the obstructive abnormalities, such as restrictive cardiac disease, would be picked up only at about this time. The other question is that there would be some that would be again picked up at this time that are coincidental findings, where these are normal variants that we don't worry about as long as they're isolated. For instance, an isolated ARSA, or a persistent left superior vena cava without a problem, or a single umbilical artery without anything else, or even a persistent right umbilical vein without anything else. These would be things that I won't attach much importance to. And then, of course, there would be things like coarctation of the aorta, which have a lot of implications, but would be picked up only at this time. And then, of course, there would be associated abnormalities that were not evident earlier, and those might then get evidence. So I've noticed a ventricular septal defect at my 20-week scan, but I realized that there's an associated bowel atresia during my later scan.
Thanks, sir. I would request my co-moderator, Dr. Jyoti, to moderate for next few questions.
Dr. Jyoti, you have to unmute.
So, Dr. Gopal, can you show your presentation?
Yeah,
I'll
sure.
continue on that itself.
Yeah, no problem.
So actually, after the counseling of Dr. Jyoti Agarwal, the patient somehow got well pacified, and she accepted the fact that, yes, this is a problem and she has to. And they decided, yes, we will go in for a termination. So once they have decided on that, they reached Dr. Malvika. And Dr. Malvika, I would now like you to answer this. So Dr. Gopal, the next slide, please.
Yeah.
And can you make it full screen? This is not full screen at present. Yeah. So Dr.
Majorly the work is done by, has already been done by Dr. Jyoti Agarwal.
Yeah.
Because counseling is a very, very important thing, and very patiently, diligently, along with the pediatrician, etc., she's already convinced the patient that she wants termination. And now the patient is going to be in a hurry to get herself terminated. She's mentally all set.
Yeah.
So talking of a legal, how will you get a legal sanction?
Sanction.
So earlier, at 30 weeks, there was no way, because there was only one way to go. That was to tell the family, or the patient is the person who's totally stressed out, and obviously the family gets connected. So the family is told that they have to meet up a legal consultant who's going to be putting a writ petition in the court. And that has to be, she has to be given all the details of the reports that are there, which have picked up the anomaly. And now they are asked to go to the court, meet up, put up a writ, and wait for the court order to come back. But now we're extremely happy with the amendment of 2021. Now we will be in a position where we can proceed after telling them to go to the board. And hopefully very nicely, Ashok has already told us that we can probably Google or go onto their site and get the details of the board and put all the details into a form, which is also called the Form D, in case it is, of course, here it'll be a Form E, wherein we will be filling up the forms which are already available in the Gazette, which is available for all of us to see and check. And all the forms have to be nicely filled up and sent to the board. And within 3 days, we do expect a response from the board. We already know that. Firstly, I do not know where the board is going to be. And I'm presuming that Dr. Asmita will be guiding us as to where, because LNJP probably would maybe one of those important places where we could be going to, and directing the patient to go there to the board, and within 3 days getting an answer, and so that we can proceed on with the process, which should be completed in 2 days. I think it is very fair, and we're very happy to be able to be in that position where we can offer this kind of a relief to the patient and the relations.
Definitely, Dr. Malvika, but only one thing that I would like from you. Suppose I get an ultrasound which shows that there's a lethal skeletal dysplasia, or let's take any other anomaly. Would we like to send this patient to a fetal medicine person for them to be able to actually calculate? Yes, this particular anomaly is compatible, or we have counseled that. I think as a patient, we should take this particular or get this done from the fetal medicine people, and then board ahead.
You're absolutely right. We do send them. Also, we have the family studies done, because it's the genetic counselor or the fetal specialist who actually does all the counseling, and so that we can give proper advice as to what a subsequent follow-up would be for her disease, etc. After having the whole family, which has been studied for this kind of a disorder existing in other family members, etc. I think, Jyoti,
definitely.
I'm happy that you brought it to light. This is very And we do it as a team, actually.
Yes, that's true. And Dr. Gopal, I think we'll have to shift the slides, or am I not able to see them? So it's on to the next question. Then it comes to us that to Dr. Asmita. In the context of an MTP Act 2021, as Dr. Malvika has said, that we are going to send it to the board. So we know a lot of things are still in the pipeline, but since we already have one board, which is there in LNJP Hospital, so how do you actually think that this board is going to move ahead, and how are we going to send it to you as far as the board is concerned? And then Dr. Sumita also is there with us for her to tell us in Delhi where the boards are likely to be formed. How are we as private practitioners going to send the patients to that particular board? What papers do we need to really fill up to send to that particular board? So Dr. Asmita, first to you.
Thank you, Dr. Jyoti. I think Dr. Khurana has very nicely covered about the constitution of a board. And as far as the context of this MTP Act is concerned, this constitution of board has to be notified by the Delhi government.
Yeah.
And as far as I know, there is no such official gazette notification of a MTP board in Delhi government till now, but they are probably considering some processes ongoing. He has already covered the composition, that it will have a gynecologist, pediatrician, and sonologist. So till now, we do not have board, but till that time, we have some board which has been constituted under the board direction. And these court-directed medical boards exist in LNJP Hospital, it's in AIIMS, and it's in Safdarjung. But they are, for approaching those boards, you need a directive from the court. They cannot directly be reached by the patient or by a private practicing obstetrician. For this, you have to again approach the court, and these cases are handled only on the court directive. We cannot handle them directly at this point of time. So I think the first priority will be for a government of Delhi to issue an gazette notification. Coming to where will these boards be situated? Obviously, now with this act, we expect a larger number of patients coming to these boards, and these boards have to function within a very, very narrow time limits. So most likely, as I expect, is that there will be multiple boards which will be constituted in the state of Delhi. They may be either situated district-wise, or they might be situated in the medical colleges with 1 or 2 districts attached to probably each medical college. That is what I expect it to happen. The exact details we will know as and when the gazette notification comes. Now,
thank you so much.
One more point I would like to add, that what challenges as a medical board we would anticipate is, number one is on timelines. It's very easy to say that the board should take a decision within 3 days of request, and the termination of a pregnancy should be conducted within 2 days or within 5 days of receiving the request. Even for a medical board, there are constraints in an institution in terms of number one, logistics. Unless the patients are fairly worked up, have a confirmed diagnosis of what type of an anomaly it is, what is its prognostication, genetic counseling it is done. For a medical board to complete that complete exercise of confirming the diagnosis, assessing the prognosis with multidisciplinary experts within the time frame of 2 to 3 days. If required, we need an MRI or we need further genetic tests. To get them done within these 3 days span, I consider it as an
sharing spouse.
A very, very big challenge, because I know for me, if I find some anomaly at level 2 at scan and I want my radiologist to give the second opinion, I really have to personally rush and do it at a personal level. Second point is, apart from this investigation, the prognostication of a patient, and suppose you diagnose an anomaly at say around 28 weeks or 30 weeks, as in this case, where it may not be lethal, but it's a poor prognosis. And we want, it's a responsibility, or rather it's one of the function of the board to ensure the safe MTP for this particular patients and direct them to an appropriate center where this safe termination can be conducted. If you have a live-born baby with a non-lethal anomaly but serious handicap, how do we handle that baby? How do we decide how serious that handicap is going to be? And are we going to suggest that there should be an feticide before we terminate the pregnancy?
Yes.
Then do we have an expertise to conduct that? I mean, all these are, I think, the questions which, as a medical board, we would find it too difficult to answer. And I'm sure the esteemed panelists in this panel can definitely try to give some answers as to how do we go about it.
Thank you so much, Dr. Asmita. I think you raised more questions, and Sumita is there with us. She'll really, since it's in the formative stage, I think she'll be able to help us out and take these into consideration. So, Dr. Sumita, if you are here with us, so have we formed any boards in Delhi as yet, or we yet have to form those boards? And how does a private practitioner reach these particular boards? Because maximum of us over here are private practitioners. We get into this problem. So if you are there and you could help us out with these two questions.
Yeah, I would say Delhi, a lot of cases already, court cases and all happen. So AIMS has this. Delhi government also has done several of, had to carry out. So many hospitals are having it, at least 2, 3. I don't have the list right now with me. So offhand, I think today I shared it with Sangeeta. I think I shared. Someone I shared it with today.
I can add on that in Delhi, I know the 3 institutions have done boards, but they are not notified under the MTP Act. They are formed under the court directive for the specific cases. And they deal the cases which are coming through the court. They are not in public domain. The list of these centers is not in anywhere in the Delhi government website. So as an individual practitioner, it's we don't know whether they will come through medical institution and how it will go.
Yeah,
so
I understand. I understand fully. The court mandate was necessary before. After passing of the act, it is no more mandatory. So they can approach these hospitals, and we are issuing direction that it has to be gazetted. Even without direction, the states have been mandated. Every state has been mandated by the act to gazette, the boards, presence of boards. So it will come very soon. As I'm telling, the guidance is ready. So we'll soon be issuing, and all the states are mandated to give this constitution of these boards and the hospital names in the gazette itself. Delhi has many, and for the time being, before this gazetting is done, I think all these hospitals, you have to approach these hospitals, and the boards are already there, constituted there. They are in place. They are permanent boards, and the notification has come to us. So that part, making it public, giving awareness to the public, all these are pending now. And we do, as I already told you, that things are, this is the first time this kind of serious, things are happening. So give us time. The guidance, without guidance, we are not writing to the states, but the states are bound, legally bound and mandated to publish it in the gazette. But I understand public, private, whether they will have to get from the public boards only. That has not said that the boards cannot form in private hospitals, big hospitals. So because MTP Act has never differentiated between public and private practitioners and hospitals and nursing homes. So this you can, if you feel, you can, the big hospitals, big setups, they can actually apply to the state and get the boards formed there itself.
Yes. I think that's a very encouraging note, Dr. Khurana.
Yeah, Shobhataji, I was just wondering that since this has to be taken to a district level, and I don't think we can just totally depend on, we don't have enough strength within the government to take it to the district level of every state. I think it becomes a responsibility of organizations and of individuals to carry this message to the district medical officer everywhere and make them aware of their duty towards us and towards the act, and say that, yes, please constitute a board within the district hospital. So I think now that we have the tool with us, the wonderful power that you have given us, we should each one of us move to districts that we can handle and make sure that the district hospital is pushed into this activity. Because we know that there is such an overload at the district hospital for clinical work that is very difficult for people to sit there and constitute such a board. But one catalyst anywhere can make a difference. So each one of us from all over the country should go to the district hospital, go to the medical officer and say, or the medical superintendent, please do constitute a board. So I would appeal to all our members and everyone present here today to go to their district hospital and get a board constituted, because that is, the rules are very clear. There is no doubt. All we have to do is that, yes, you've given us the handle and we will move it.
And Dr. Krana, Dr. Sumita is saying that yes, private sectors too can do it.
Yeah.
Very encouraging. So we have many of the private sectors which can handle and they can do it. So I think we need to take it over to our own private sector hospitals too.
So yes, yes.
So moving on to the next question, Dr. Sangeeta, this is for you. So now the board has given you a sanction. Let's imagine we have got the sanction. We've been very lucky. Now, if the patient comes to you in your particular hospital, what are the things that you actually are going to go through before you do the termination? Legally, what papers are you really going to look at?
So once, I know everything is new to all of us, so this is all imaginary. Once we get the sanction, we have to in detail talk to the patient, because telling her all about the options available to her, of course they are very limited options, all about the side effects or about the positive points of the procedure as well as negative points of the procedure, and detailed informed consent has to be taken. You know, till date, what we are doing, we are filling Form C for the consent of MTP, which is a very small consent, which I think all of us will agree is not a proper consent for a late termination of pregnancy, where there are more chances of complications. So we have to explain that she has to give the informed consent regarding if laparotomy required, if any surgery required, and it has to be told to her in detail. Then we have to really calculate and completely calculate the period of gestation, rightly calculate the period of gestation, because it is going to make difference in the type of procedure or method we are using for termination of pregnancy. Then the congenital malformation has to be again verified and reconfirmed. You know, there is shortage of radiologists in government hospitals. So many discussions are going on that how to increase the number of radiologists in government hospitals. So to get a second opinion, I mean that this patient is coming after the permission of the medical board, it is a different situation altogether. But in general, what we are going to face, as rightly said earlier, that to get the second opinion for confirmation of the abnormality is going to be very difficult with us. But of course, we have to confirm it. Then we have to take the previous clinical records of the patient, genetic tree of the patient has to be formed, and she has to be told about the recurrence. If our genetic assessment tells us, then we have to tell about that. So all this detailed counseling and informed consent, the telling about the procedure is required.
Yeah. And probably filing them and documenting them. I think that,
of course, that is very important.
Yeah. Yes. So thank you so much, Dr. Sangeeta. Now we come to the more of an obstetrical question. So now we have decided that, yes, we are going to terminate this pregnancy because this is something which is uncharted. Going through the literature, it's very difficult to see at present because we haven't done it for a fetal anomaly at 32 weeks. If the MTP board has given us the permission and we have to terminate this pregnancy. So Dr. Asmita, what method would we use? What protocol would we follow to be able to terminate this lethal fetal anomaly? So in very short, but yes, in government sector, exactly what protocol would you recommend to be used?
Yeah, first and foremost, I think we need to counsel the patient that with a word of an MTP, the concept that this is something which is going to occur very swiftly and in a short time. So we need to tell the patient that it's practically going to be like a normal delivery. Coming to the modality, how we terminate this pregnancy. By and large, in our institution, I would prefer to use a cervical priming with an dinoprostone followed by an oxytocin induction. Most of the literature, FIGO guidelines, WHO, everybody is recommending misoprostol for the termination of a pregnancy. But there is some controversy and some doubts regarding misoprostol. And I think this is one area where we do expect Government of India to work on. If we look at an DCGI guideline, it says that misoprostol is approved for cervical ripening. It doesn't use the verb induction of labor. Second thing, your FOXY GCPR guideline also says that misoprostol is not yet approved for the induction of labor. So this is one gray area which needs, it's high time that it's sorted out, because there is enough evidence worldwide that misoprostol is a very, very safe and equally effective option for termination of a pregnancy. So normally for us, we would prefer dinoprostone followed by oxytocin, but misoprostol is an effective drug option. As a safety precaution, we use misoprostol as a second line if dinoprostone doesn't work with an consenting, that this is unsafe and it has been recommended. The regime is already projected. The dose for induction of a labor beyond 28 weeks would vary between 100 to 200 depending on the situation for induction of labor. And for a live and IUDs, again, the doses are different. So depending on the clinical circumstances, we can use misoprostol. So essentially, it's like an induction of labor done at an earlier gestation.
Yeah. And Dr. Asmita, one thing I would like to know, when would you like to take this patient for a cesarean section and say it has failed, that it is not working any longer? So what is the duration that we would say that 24 hours, 48 hours, how much are we going to give the time, and what is the protocol that we would say?
You mean to say in the cesarean for failed induction?
Yes, ma'am. At 30 days, because it's very unlikely.
Yeah, I do agree with you. I think by and large, because the fetal anomaly is lethal and we are not giving fetus and much consideration, I would like to do induction. If the induction fails with whatever definition we use, we won't do artificial rupture of a membranes, because if patient does not respond within the first cycle of an induction, we may like to give her a rest for some time and consider the reinduction at a later date after the gap, because here the concern is not the
baby.
fetus.
Yeah.
So in that situation, we would prefer to avoid the cesarean for failed induction of a labor as far as possible, unless there is some complication like she ruptures membranes, there is evidence of chorioamnionitis or antepartum hemorrhage or something.
Thank you so much. And I would like Dr. Malvika here from private sector to say that the protocol change over there and how would you handle this patient?
No, thank you so much, Jyoti. Actually, what Dr. Asmita said, we are following just the same. We are using a lot of dinoprost or Cervigel to have cervical ripening and follow it up with oxytocin. And also misoprost I've used a number of times. One very important noticed that if you're counseling your patient well, they are mentally stable, because that is something which is very important for them. They would be open to the idea that in case the induction has failed, you could give them a little more time and reinduce her after a gap, which could be as much as, I've done it even as much as maybe 5 to 7 days, because this is the time at 30, 32 weeks that it's a little difficult induction. Always prime up, because one thing wherein the whole family works together is when you tell them that this is only for the betterment and she will not, it'll be more for vaginal delivery rather than giving her a cesarean. So they are quite open, and in private, they do accept it.
Yes, that's
we do spend a lot of time talking to them and counseling.
So the counseling says that they should be ready for a prolonged induction, but we have seen 90 to 95% will deliver vaginally unless there's. The one very good question that Dr. Asmita raised, and since Dr. Samita is here, and probably when they're forming, they can do is, suppose the baby comes out live, and this particular baby would require certain time in the NICU. So can we use KCL or any other particular method to stop the heart prior to that? Or is it going to be included in the act that we're going to go ahead, so that at least when the baby is out, the mother doesn't get that particular mental problem and the agony of a live baby with severe fetal anomaly? So if Dr. Khurana, you have this, or Dr. Sumita, or it's just a suggestion?
Yes. So primarily, we do understand that if we let the fetus be, a lot of these fetuses, anomalous fetuses, will be born alive. Yeah. And we have no right to put an end to life. We have to provide comfort care as dictated by the family choices. The fact why this has not been included in the MTP Act is that MTP always involves expulsion of the products of conception. So a fetal reduction, as we would call it, or putting an end to the fetal heartbeat, is actually to be done as part of a therapeutic procedure, which then does not come under this kind of the MTP Act. So there is the precedence that we will follow, just like they follow all over Europe, where terminations can happen at any time, that we will put potassium chloride after counseling the family and the patient of the risks of potassium chloride, that we will bring the fetal heart to an asystole, observe it for a period of time, and then go ahead with the termination of pregnancy.
I have a question here, Ashok.
Yes.
May I, Jyoti, ask the question?
Yes,
Yeah,
yes,
please, Dr. Man.
Ashok, I was kind of going through all this use of potassium chloride, which we have done for reducing, when you have triplets, etc., before 12 weeks, we've done it. But now when you talk of a child, a fetus which is 30, 32 or 36, because there's no upper limit to the termination which has been put actually. So I was just thinking through that after 24 weeks till when. Now here is a 38-week baby, whether you use a ACL or a digoxin or, Ledu, whatever. So you're doing a feticide. So where do we stand for that? And if this is something which is, will it be included in the law, like what Jyoti asked you or asked Dr. Yes, Dr. Ghosh, as to where would we stand for that? I mean, it's a feticide. And of course, the induction would be much better because it would be easier to induce a labor after there is
a stillbirth,
after there is an IUD. So that being so, I think we should seriously put our mind to it as to how. And there are, worldwide, there are countries who are doing it. There are countries who are not allowing it. But where do we stand in India? We'll have to think about that.
No, I think the law makes it clear that this doesn't come under the MTP Act, and we just put the fetus come to us on the request of the family and permission from the family. We will do a feticide.
Ashok, I'll just share one thing, because I'm sure the family is going to be willing for this, because parents and all would not want to have an abless child given to because it's a huge liability to a young couple.
Yes.
So they would be very much with us for that.
Yes.
So, Dr. Khurana, so what I understand by what you have said, that once a medical board says, yes, this baby can be terminated, we send the patient to you and you would help us out by putting the KCL and putting the baby to sleep. So is that?
Yes, well, the only thing is that we don't like to do these as an outpatient procedure. The amount of potassium chloride required can be considerably high, and we need to monitor the mother non-stop to make sure that she doesn't get a hyperkalemia and she doesn't go into a cardiac irregularity. And therefore, we will do it in a hospital setting.
Yeah. I think that's made it very clear for a lot of us over here. I think that's definitely.
And I can do that at 39 weeks. I can do that at 40 weeks. It's well within the law.
Yeah. Okay. Thank you so much, Dr.
Thank you. Thank you very much, Ashok.
So we come to the next particular question. I think we are running a little short of time, but in case of a previous cesarean, that's a scarred uterus. Now that's a big problem. 32 weeks, we could wait and give her more of misoprost. But when she comes to us with a scarred uterus, we are going to terminate her. Dr. Jyoti, getting you onto this. The protocol is going to be a little different.
Yes, definitely. First of all, I would like to counsel the patient about the mode of delivery and the place of delivery as well. Mode of delivery, I need to sit up with her and tell her you can either deliver vaginally or you can opt for a cesarean section. But at the same time, if she opts for a vaginal delivery, I need to tell her, since the uterus is not prepared for delivery at this time, you may be needing higher doses of all the inducing agents, and no guidelines so far recommends the use of misoprost for induction of labor. And and if she opts for cesarean section, that's a different question totally altogether. But in case she opts for vaginal, I would like to first ripen the cervix by intracervical insertion of Foley's catheter, leave it for overnight. And once the cervix is soft and dilated and the Bishop score improves, then I will augment
with
mesoprost. No guidelines so far says about the mesoprost, but most of us are using it in very small doses, but with a very caution that we should have a very good monitoring of the mother. We are not concerned about the fetus right now, but a very good monitoring of the mother in case she ruptures the uterus, though the incidence is very, very less. It's hardly 0.3 to 0.4%. But it has to be done in a setup where we can have this kind of monitoring then the oxytocin dose has to be either it can be given orally or vaginally. We usually prefer the vaginal route and we give 25 micrograms. And depending upon the Bishop score, we may repeat it 4 to 6 hourly and then do an early ARM and then deliver the patient. So my protocol would be to put a Foley's catheter and then mesoprost, ARM, and then deliver.
I think you're talking of oxytocin. I think Foley's catheter followed by
oxytocin.
Yeah.
Dr. Jyoti,
Yeah,
the method of termination will much depend upon period of gestation, whether it is before 26 weeks or it is after 26 weeks. Because
this particular okay.
In previous in case of previous because we can give after cervical rightening, we can give mesoprost safely before 26 of pregnancy, but not after 26 weeks of pregnancy, because they say, but it is said in FIGO guidelines also, they say that it's only 0.4% more chances of rupture in a case of previous cesarean if we use mesoprost there. Otherwise, later than that, we can do a cervical priming, and after that, we can use syntocinon for the patient with a good, under a good monitoring system.
So I think the consensus over here lies is we have to be very careful about mesoprost, because apart from NICE, no other guideline has recommended mesoprost for the induction, be it FIGO, be it SOGC, or be it ACOG.
Yeah.
So only thing
can I make a point here? Though there are no guidelines, but we at Safdarjung have been using mifepristone 200 milligram TDS for 2 days in previous 2 cesarean also with IUD, and we have had excellent results without any mishaps. But then there are no guidelines. This is just a series we are doing, and
included. This has been included in the green guideline, which is of 2010.
Yeah, can I come in?
Yeah, ma'am.
Recently, a NICE guideline has come just as recent as 4th November of 21, which does recommend mifepristone followed by oxytocin and misoprostol for induction of labor.
Yeah.
So, I mean, now it's in the guideline that mifepristone is definitely good for cervical ripening, but obviously not for induction. You need to follow it up with either oxytocin or misoprostol. And as far as previous section is concerned, the product monograms of all the drugs, whether it's dinoprostone or whether it's misoprostol, they list previous cesarean section as a contraindication. So it's a call between an obstetrician and patient how much risk they want to take.
Exactly.
So consenting is very, very critical in previous cesareans, especially because all guidelines say it's a contraindication.
Yeah.
And I would like to highlight one thing, that they have to be counseled about a bit longer labor, a prolonged labor as compared to the thing, because we are not left with many options. We have to be tolerant. She has to be tolerant. We have to be patient, so that she has to be properly counseled about a prolonged labor.
Jyoti, I've used Cervigel very often, and it comes out as Cervigel followed by with oxytocin. It gives very good results.
So the various options that we put with cervical ripening after the panel discussion is that we can use a catheter. That's a Foley's catheter, which we leave behind, which can be followed by oxytocin, ARM, and then we follow it up. Or we can use Cervigel. Yes, many of the hospitals in the government, as well as that, can be used Cervigel just for ripening, followed it up by the oxytocin. But if you look at the guideline that is of the IUFT guideline of NICE, which says 200 milligrams mifepristone twice a day for 3 days, or thrice a day for 2 days, that's 600 milligrams for 2 days. They say about nearly 70%. And this is one of the papers that is 2019 from India itself, where they have done RCT, which is not non-blinded, on 52 patients. And they have found that using this mesoprost, they've only given 400 milligrams once today and then again repeated it the next day. And they found that nearly 80% of them worked vaginally. And that is it. So we need to do more studies. And I'm sure in the government hospitals with so many senior people sitting there, we can use this as a see whether mifepristone itself leads them on to labor, especially in the previous cesarean sections.
Yes.
Coming on to the question, I think, Dr. Gopal, this is over to you for the next part of the panel. So Dr. Gopal, are you there? Could you unmute yourself, Dr. Gopal? Yeah.
What are the investigation would you like to consider in case of a lethal anomaly postnatally? Dr. Shokurana, sir.
Yeah. So the most important thing is that whenever we have such an abnormality, the first question that the patient will be asking us is, why did this happen to me? And the second question is, will it happen again to us? And we have to answer both these questions, and we encourage patients to ask such questions, and we like to answer them. And therefore, we have to ensure that deliveries don't take place at home, for instance, or in a place where the chance to investigate is missed out completely. In the Indian context, it is wiser actually to try and investigate antenatally as much as possible, because patients do tend to get lost to follow up, and they have family pressures as well, which they cannot withstand. So at least from a point of view of just doing an amniocentesis so that I can store up the DNA would be something I would like to do antenatally. And you can do this on a stillbirth fetus as well. And that would be the ideal thing to do. If it is an oligoamnios pregnancy, then I could just suck up some of placental tissue, and that will also give me a reasonable amount of good tissue from where I can get my DNA from. I don't need live tissue for DNA. Then postnatally, the first thing, of course, would be a visual inspection by the obstetrician or any of the residents who happen to be present there, or any radiologist who takes interest in such work, and you make a list of the abnormalities that are evident. The second thing is clinical photographs, where we can actually put intelligent use of our cell phones and use them for these kind of photographs, because a geneticist or a dysmorphologist would be able to use this very, very usefully. The third thing is the fact that, as you have shown here, there is an infantogram, and that can be done, which will show us soft tissue anomalies as well as osseous anomalies. The ideal situation, of course, would be to do a detailed evaluation using a fetal autopsy or postnatal genetic testing. And when it becomes available, we can do what we call a micro CT. And so that would be extremely useful. The fetal autopsy is something that we have to start counseling for even before the procedure happens and during the actual procedure of termination of pregnancy. And therein we tell them that, look, if you want all the answers, and this is important for the seniors in the family, if you want the answers and if you want to know that it didn't happen because of you passing it to your son who passed it on to this child, then you better do these investigations. And so then an autopsy would then be done. If an autopsy is not available within that institution, we must understand that we would like to prepare these samples in the correct possible way, and that if we send these samples without preparing them, there is a chance for autolysis, particularly that of the brain. So what I would do is, as soon as the fetus is delivered, I would take formalin and inject it through the anterior fontanelle into the fetal brain so that there is no autolysis of the brain. We then take the entire fetus and put it into a large bread box, fill it with formalin, and put the address of the lab where you would like the fetus to be delivered. And these can be delivered even by couriers, because couriers now have the authorization to carry human remains. These are fall under the category of human remains. So couriers can take them, and airlines as well as railways can take them. And that would look after that. If the patient is not willing for an autopsy, we must at least try and get genetic material. And the two sources of genetic material would be a 1-inch square cut portion of the placenta around the level of the insertion of the umbilical cord. And I cut it with a scissors or whatever is available, or with a scalpel that is available there in the OT. And I put that. And then again, in this, you don't put it into formalin. That is something that can be sent in any physiological fluid. And all you need to do is to add normal saline, and that is more than enough. If this gets infected, we are not really worried, because in the presence of infection also, I can still get fetal DNA. So that's not a problem.
Thanks, sir. Thanks, sir. Next, please. Next, please, Dr. Jyoti. we will take a short case because the time is the short here. So the case 2 is actually G2P1 previous NBD with a live baby of 2 years, and she has come to clinic at 20 weeks, and she has had no previous scans. Next, please, Dr. Jyoti. So, in the light of MTP 2021 Act, should we postpone her anomaly scan to 22 weeks as we are discussing, or because this is not fully worked up, so we should do it at 20 weeks? Sir, please.
Dr. Khurana, this question is for you, sir.
Sorry, yes. So you see, the point is that when we have this particular question, it becomes very straightforward that we now have the luxury of going all the way up to 24 weeks and beyond. And therefore, irrespective of when the patient comes to me, I will do a full workup and not get worried about any sort of time dangling on my neck.
So, sir, what we understand for the obstetricians, to clarify, that now we can send our scans at 22 weeks for an anomaly scan, because you could also do a good cardiac screening at that particular time.
And a much better one than before. The question really arises is that, are 2 weeks really enough? I mean, we've got used to the 2 weeks by sending our patients at 18 weeks.
Yeah.
The question is, are we going to get used to, is 2 weeks enough, or do I require 3 weeks? And therefore, I would say, okay, let's say 20 to 22 weeks would be ideal, because that still gives us the luxury of time. And until, it's going to take us a year to get into the new system, at least by the time we get support from the medical boards. And so until then, I guess we should shift the 20-week scan to the 20 weeks window, the 20 to 22 weeks.
2 weeks.
Yes. Yes.
I think that's a very important takeaway message. Yes.
Yes. Yeah. Very important. So, patient herself delayed the scan to 22 weeks, and the fetus was found to have an encephaly. So, how would you terminate her pregnancy? Dr. Asmita first and Dr. Jyoti next.
I think at 22 weeks now, under the new law, the things are quite simple. You need an opinion of 2 obstetricians, and it is to be simply recorded in Form E. We don't need to go to any medical board or anything, and can terminate the pregnancy. Right. As far as methods are concerned, the Comprehensive Abortion Care Guidelines of Government of India has given the guidelines for 2nd trimester termination, and we can follow that. The methods which are listed in CAC guideline are the use of mifepristone, misoprostol. They have also listed dilatation and evacuation, but I think most of the situations we are not using dilatation and evacuation for pregnancies of 24 weeks. We by and large restrict ourselves to the dilatation and evacuation till 14 weeks of gestation. But that is a theoretically option. If there are some centers which are used to that particular technique, that's fine. And the third option, which we quite often use, is the use of an ethacridine lactate. The guideline also lists that possibilities of intraamniotic saline and all, but these are not the methods which are recommended internationally for termination of a pregnancy. So essentially, it boils down to mifepristone and misoprostol as a first line choice for 22 weeks of pregnancy for all practical purposes. And of course, it has to be done at an approved center, which is approved for the 2nd trimester termination. Now, with this act, we need the approval for centers for 3 different categories. One is a 1st trimester termination or a medical methods. Then we have a 2nd trimester termination, and then we have a late terminations. And the facilities and what are requirements are adequately listed in the act, which we need to be aware of.
So one thing for Dr. Sumita, because again, the centers which have got a 20-week sanction, do we consider that now they can do to 24, or do I need to go back and get a new permission that I can now deliver till 24?
See, here comes the catch. The present certification is up to 20 weeks.
20 weeks, yes.
And the intent of the act is that whatever is good for 20 weeks is good for 24 weeks. So See, theoretically, all those who have been approved for 20 weeks will be now 24 weeks. But again, certificates you cannot change yourself. So DLCs you have to, maybe apply, but there is no new, this thing will be issued, that new, again, approval, again, certification, verification. All these things are not required. But for safety, if anything unforeseen happens, you have to remain clear. So whatever certificate you have is 20 weeks and they will be valid for 24 weeks. But it is better that DLCs will also instruct the DLCs also that can be, certificate can be changed. No new process will be involved, but the certificates, I think, to protect, because see, MTP Act is to protect the women as well as the provider. Both are safeguarded by the Act. So for the best interest of the provider, we will issue notification that the same centers who are approved for 20 weeks will be now approved, but the certificates need to be changed. Now that part has to be done. We'll do it, but for the time being, they will stand good.
Yeah. Thank you so much. Thank you so much for this clarification.
Thank you, sir. Sir, in your vast experience, after this MTP Act 2021, what has changed? Can you briefly give a certain message, a brief message to all the person working in fetal care, or radiologists, fetal medicine especially, that what has changed? Those golden words, sir, please.
So 3 messages. The first is that all of us have to find the right person within the government machinery to support us on this. And I would like to take this opportunity to thank Dr. Shumita Ghosh for being with us these past few years and ensuring that every woman gets empowered because of this act. And that we should not give up, that as individuals, we can achieve this. And all we have to do is to have the right support from government. The second message is very clear, that anomaly scans will shift to the 20 to 22 weeks window. Yeah. The third one is that the Act places a sense of responsibility and ethics on every practicing obstetrician. And yes, the boards will be in place to oversee what is going on, but we must, as individuals and practicing obstetricians, not do random MTPs on the basis of trivial abnormalities, such as treatable abnormalities like an isolated clubfoot, an isolated cleft palate, and so on. Before 20 weeks, yes, we may not have a control, but certainly as it comes to later in pregnancy, this act places a huge responsibility on the practitioner. And we are grateful to the government for accepting the fact that the medical profession is ready to take on this responsibility, but we have to make sure that we keep it up.
Yeah.
Thanks, sir. Thank you so much. Now there are several litigations in the world by these children who got born, and now they are suing the doctors, they are suing the parents as well. So all the panelists, just a single line about what is the rights of the fetus, what you feel.
Starting with Dr. Malvika.
Dr. Malvika, ma'am, please. Just one line. What is the right of the fetus? What do you feel right?
Whoever is comfortable to speak. Yeah.
Actually, no.
Yes.
Yeah, I think what Ashok said, that it's a huge responsibility on us doctors to be very, to be very fair and understand as to what is a very lethal abnormality, which is not going to be good for the child when the child is born. Because in case it's going to affect the day-to-day working of a little child, the infant who comes into this world will be. So it's the right to life, which I think, if you remember the 4th Geneva Convention, which would said that every conceptus, when the pregnancy happens, the unborn child has already been accepted by the family, by the government, by everybody, that it is there and the child has a right to life. So only it's going to be affected, the life is going to be affected. That is the time when it's the doctor's responsibility to understand, like Ashok very nicely mentioned, just for a clubfoot, we've had patients who ask for a termination,
Yeah.
which is so easy to correct, So I would just end on that.
Dr. Gopal, maybe we are running a little late, so a lot of people are leaving. We're already 10:07, so we could probably consider ending it if it's okay with you.
Okay. Last, but not the least, an urge to get registered for our first on-site event after COVID. It is such a nice topic. You can see the Gujarat and feel like that we are all back to the life. So please get registered for this event.
Registered.
That is my urge. And thank you so much for being part of this panel. All the esteemed faculty, the GIF, SFM as well. I will urge Master of Ceremony, Dr. Meenakshi Sharma, to take the questions to the panelists.
Thank you. It has been a very great session that we had today, and we had so many questions which have come up and discussed very well in the panel, but still there are many more questions which are going to come up in near future. And many of the questions, though already discussed in the panel discussion today, but a few questions remained. And one of the question was regarding the fetal echo. Like if we are doing a level 2 at 20 to 22 weeks, then should we be doing a fetal echo again at 20 to 24 weeks, or we can do the fetal echo at 22 weeks itself? That was one question which was posed today.
Dr. Khurana, this is for you.
Yes, so we do understand that within the routine anomaly scan, we have a section of the fetal heart which can be evaluated. However, this is a limited evaluation, just like we have for all the other organs. Therefore, we now have a list of indications for a fetal echocardiography. And if the patient falls into that list, which can be maternal causes, fetal causes, and environmental causes, then we must do an additional fetal echocardiography, because the extent of cardiac evaluation is different in a fetal echocardiography versus a routine anomaly scan.
There's another question by Dr. Rajendra Khanal to what are the criteria for microcephaly in fetuses of Indian origin? I think Dr. Khurana, sir, it's for you again.
Thank you. Yes, there is no doubt that the head circumference is different in different populations. However, we have decided in general to shift from customized charts to standard charts. In that situation, we will use exactly the same definitions we use. So if I were to use and say that, look, it was my BPD less than 4 standard deviation, which was the oldest definition, then I will stick to that definition. If I say my head circumference should be below the 3rd centile, then I will stick to that definition. So the same definition that is for the rest of the world now applies for every Indian baby as well.
Okay.
But actually, we'll just entertain 2 more questions.
Okay, ma'am. Dr. Anjali Gupta wished to ask, how do we approach medical board in states, for example, Uttar Pradesh, if we need to terminate a more than 24-week pregnancy with anomalies?
So as we've discussed, the states are beginning to constitute this, that the list will be ever increasing, and we'll make sure that this becomes available on our AOGD website, which I'm sure Dr. Achla will be only too happy to do. And we will also put it onto the SFM website. We thought we'll put a list together first, but I think as we keep getting information, we'll keep adding to the list, and we will be in touch with Dr. Shumita Ghosh for facilitating this from time to time.
Dr. Meenakshi, one question for Dr. Sumita, which I failed to ask in the panel. Madam, there's about the 20 to 24 weeks, it says 2 RMPs are supposed. What is the qualification of the RMPs are we talking about? Are they going to be obstetricians and gynecologists, or according to the previous Amendment Act, anyone who's worked 6 months in a obs and gynae or any of that sort? So just that particular question I would like you to answer.
Yeah, it was, in previous act under the rules, the qualifications were defined. So beyond 12 weeks, there was a set of qualifications. The same set of qualifications will apply till 24 weeks. But practically, we have pushed the 20 weeks to 24 weeks. So it will be either an obstetrics or gynecologist by default, or someone with 1 year of experience, or someone with a done a house job, or in 6 months. So these were the 3 categories which were allowed till 20 weeks. So the same will
It will
apply.
continue for 20.
Yes, but two of them have to be there. See, what I want to here, that we are beyond the whatever is written in the Act and beyond whatever is written in the rule. Our guidances will be basically for how these boards and all will function. The clinical part, the procedural part, the special part is left to the medical boards and the specialists, and we really don't want to give the any kind of guidance on that, because it will vary at a district level where the expertise is less. So where they will whether the boards will allow or not, and at
Thank you.
sorry so so the boards will have to decide, and they will decide that primary responsibility will be the safety of the woman. So whether that circumstances, the requisite is available, or requisite facilities are available, all this will count. So no such guidance will be given from our point. The method, all this will be decided by the board and the doctors. So my request will be that private sector has a very big role to play in this new extension of gestation, and I really request that learning from this whatever discussions are happening around. So I would really appreciate if you can send me your suggestions and all, so that we can incorporate, like things are coming out that the list should be made public, they should be there. So all these suggestions I would really appreciate.
Thank you so much.
Madam, I just want to make one thing to everybody, that anybody who has got a second trimester termination approval center, they must write an application tomorrow itself, that this should be changed from 20 to 24 weeks. And without the you just inform them and keep that particular copy with you, so then you are safe.
Yeah, be safe. And the DLCs also will write to them that whatever centers are approved for 20 weeks will automatically they will transit to 20. So
but
that
Dr. Ghosh, one thing is I find, let me take the bad side of we people. We don't have a uniformity as for the procedures are concerned. And there, I find somebody uses Foley's catheter, another uses mifepristone. Some guidelines should be there.
Madam, Foxy has to take initiative. I think Foxy has to take initiative.
See, we cannot guide the experts. The experts.
No, I agree with you. That we have to do it.
Yes.
Yeah. See, as I said, it depends on the situation. It will depend on what place it is. It will depend on what which metro it is, where how much facility expertise is available. So we cannot give a general guidance on what method to follow.
But we end with a note, that the safety of the woman is first.
Yes.
The safety of the woman is first.
If there is any doubt that this procedure will not be safe, I think the board should decide that yes, continue the pregnancy. We cannot play God every time. We need to know our limitations. So when the expertise is available, the Act has permitted. But when the expertise is not available, where the things are in doubt, I would request that the boards be cautious. The boards take a stand, which will be ensuring the safety of the woman first.
Because our society is ruthless, Once it's a malformed child, what happens to the woman doesn't matter, but they want 100% right child.
Yeah, yeah. Yes, yes. I know this is going, the intent of the act is to, help the woman, but this can actually, allow, permit them not to have, even if they want to have, they might not be allowed. So all these issues are there. So I really request everyone to be very cautious while, applying this act, and be sensitive towards the woman, and her safety is the utmost of importance for us.
Medical board is going to play a very important role in that, because they should be the one who are going to decide whether it is safe for the woman or not. So the people who are going to be part of the medical board should be very carefully chosen, and they are going to be the most important people deciding.
But I think, Dr. Achla, some basic guidelines have to be made by the local, state bodies like AOGD or anything for bringing it into the forefront.
Definitely, we will.
I think we've had
it's a Herculean task, actually.
Very Herculean task, because it's so diverse. Methods are there and so complicated things are there. One has to unite somewhere and follow that.
The number of people who are going to be on the board also has to be really high, because these kind of problems we are facing, all of us are facing. And if the interval is only 3 days, you have to do so much.
Meenakshi, please wind up. Thank you very much.
I would request Dr. Gopal to give
We had a highly successful webinar today with attending more than 330 participants. And
Madam,
still at the end of
350.
350 plus, and even now 140 participants are still logged in. And I request
more
Dr.
than 140
to please say a vote of thanks and conclude this webinar today.
That is a single sentence vote of thanks for all of you. that I am thankful to all the faculties here to be part of it and making it so successful. I'm thankful to my sponsor also, Lifestyle, and my thanks cannot be given without including my backup team, Vishalji and Conference International. Thank you so much. Good night.
And I would just like to add my special thanks to Dr. Sharda Jain and Dr. Ashok Khurana. It is they who actually conceptualized it, and they are the ones making us aware that we need to stand up and do it. And
pushing as always. Thank you, sir. Thank you, ma'am.
And Dr. Sumita, thank you so much for joining us.
Dr. Ghosh, joining of Dr. Ghosh has made a tremendous difference.
Absolutely, great.
Correct. Yeah. Thank you, sir.
And to get Dr. Ghosh, I think the credit goes to Dr. Achla Batra. And here I wish to just only tell one thing, that Life Cells have started an autopsy, and their autopsy is not very costly, and it is available. Very detailed autopsy is those people do it. So that's available for a private sector. I just wish to inform them that, I've got it done recently for 2 cases, and it says detailed this thing. And finally, the credit goes for this particular CME to Dr. Gopal. He only said as a secretary of the Fetal Society of India is that, Dr. Jain, we must have it under the banner of the DGF and this thing. So I think the credit of this particular meeting goes to Dr. Gopal and Dr. Jyoti Bhastra going ahead and organizing it. Thank you very much, Dr. Gopal and Dr. Jyoti.
Pushing the factor is always you, and we are making a positive position statement very soon for you.
Thank you so much, sir.
Thank you. Have a good night, everyone. Dinner is waiting for everyone, and a good sleep after.
Thank you
so much.
Thank you. Thank you.